So hopefully most of you know this, and I'm not going to spend much time on this, but it's just to set the scene really. So the BHF Data Science Centre, which is coordinating this activity, was launched in 2020. It's part of HDR UK, and the focus is around being a UK centre for expertise in cardiovascular disease. And I like to broaden that out to cardiometabolic disease, as in that's why diabetes is part of the BHF Data Science Centre. It aims to create strong partnerships in health data science and to involve patients and public to build trust. And so there is a number of thematic areas within the BHF Data Science Centre. And again, I won't go through these in details, but these range from personal monitoring data, imaging data, defining cohorts, clinical trials, and you can see them all there. So after the BHF Data Science Centre was set up, there was a number of what we call catalysts set up. Diabetes was the first catalyst, and we've since been joined by stroke and kidney catalysts. So these are funded by the relevant charities with the BHF, and obviously they have a focus to broaden out the cardiometabolic space into diabetes, stroke, and kidney disease. The Diabetes Data Science Catalyst, now we've been running for about 2.5 years, was set up really to try and provide guidance so that people could find out more about what was available, and therefore to increase the use of diabetes data sets, and really the communities of practice has emerged from this. To spend some time defining diabetes and types of diabetes within electronic medical record systems, which we're going to come on to expand the research possibilities of diabetes cohorts, so those consented cohorts that people have collected, and to support a number of driver projects. I'll outline those briefly, and all of this embedded within working with people living with diabetes. So these are the driver projects we funded. These were short, small amounts of money to two groups really, plus me. I didn't receive any money for it. So we've been looking at impact of COVID on type 2 diabetes and cardiovascular disease. What we'll hear later from Carlos in terms of the impact of COVID and on diabetes and pregnancy care pathways, work that I'm doing with Huan Wang on SGLT2 inhibitors and ketoacidosis and COVID-19. And then another parallel piece of work that Marion Maffin from Oxford is leading on, which is looking at really, I suppose, defining diabetes within trials data sets and how trial definitions and medical record definitions align. So I mentioned that we're doing some work around defining diabetes, and we have convened a number of workshops now where we have got groups together who work on data to define diabetes type and date of diagnosis. Many of you have been involved in this. You can see we had lots of groups sign up to this and help us, and we are at a stage now where we have now got what we think is the consensus view of the definitions of, or the code list for diabetes, how you define type of diabetes, type 1, type 2, other, and how you define date of diagnosis. And just to give you an example of some of the work that we did, we took all of the code lists that were available from HDR UK phenotype library, and you can see those are just listed along the top here, quite small. And when they look and see which of those data items are used in each of the code list definitions. But then what we could do, which was very neat, was then say, well, how often are people uniquely defined by one particular code? And not surprisingly, the most common code was type 2 diabetes. But what we noticed was there was a code that kept on cropping up that defined a lot of people as having diabetes uniquely. No other codes define them as having diabetes. And actually, this code is not a diabetes code. It's a generic QOF code. So there are a number of code definitions that use this code. So we are obviously making sure that that is removed in future from all potential phenotype code lists. So just an example of what we've been doing. So moving on then to communities of practice. So why have we set this up? Well, it's an experiment. It's to try and see whether or not we can create an interest around the UK, getting people together who work on diabetes data. So it's meant to be this place that we come together, we hear what people are doing, and we build up collaborations, improve links, hopefully get joint grants that we put in together. So it's around you all finding out about who is out there and what you do. So on that basis, obviously you're all here, and it's always difficult to find out who's doing what, and particularly when we've got 40 people on the call. We have generated a Google Doc that hopefully Amy will share if she's done so in the chat. Yeah, and so that currently is probably unfilled, but we want you to be brave and start typing. Maybe not during John and Carlos's talks, although feel free if you want to, if you feel you can multitask efficiently. But we want to capture who you are, what you do, what you're currently working on, and yeah, put a few publications in that you're most proud of, with your PubMed IDs, and whether or not you would want to present at one of these sessions. What we want to do over the course of a number of these communities of practice is get people presenting who work. Initially, the plan would be to get people who are working on different data sets, so we can hear about who's working on CPRD, who's working on Open Safely, who's working in the NHS, SDE, so we can start to hear about what the data is out there, what are the strengths and weaknesses of those data sets, and what are people doing with those data sets. But this Google Doc, I think, is really important. That is the start of the community. It's open to you all. And there's no restriction on that, as long as, so by putting your name on, you're essentially agreeing to be contacted by any of the other researchers on this call. So we start to build up these contacts. So that's the idea. Our plan at the moment is to have these quarterly, but we're going to send out a survey at the end to get some feedback about how you think it went, and how frequently you'd like it, and how differently or not you would like this to be. So I think that's probably all I should say. I shall, as I've said, we've got two talks. John Dennis from Exeter is going to be first, followed by Carlos from Edinburgh. And as I say, we should have 15 minutes at the end for Q&A. So let's get started. John, did you want to take over?
Yeah, sure. Thanks, Ewan. Hi, everyone. Great to be part of the first session. Just let me share screen. Good. So can everyone see that okay?
Yeah, perfect.
Great. So I'm a health data scientist based at Exeter, and I'm going to talk to you today about some work that's now as part of the UK Mastermind Consortium, which Ewan is also a key part. But really, this is about... Oh, sorry.
You've got a slightly dodgy connection, I think, John. I wonder whether we should all, other than John, just turn our cameras off to try and help.
Should be okay. Can you see?
Yeah.
Can you see okay? Yeah, okay.
Seems to have settled again, I think.
Okay. Yeah, so I'm going to be talking today about some work we've been doing using UK electronic health records alongside data from clinical trials to develop a precision approach for type 2 diabetes treatment. So just before we start, and in the interest of collaboration, as Ewan nicely highlighted, just to flag that underpinning most of the research that I'm showing today has really been a reproducible open source pipeline that we've been developing at Exeter over the last few years to develop research-ready diabetes cohorts using CPRD. Aspects of this are feeding into parts of the work around the data science catalyst, particularly around defining type 1 and type 2. If you're interested to see more, please head to our GitHub or reach out to me, and or Katie Young, who's the lead on this work down here. But really, one of our main interests in terms of using UK electronic health records has been this idea of developing precision medicine approaches. And what we have been doing really is focusing on the individual person living with type 2 diabetes, like Claire and Anthony shown here. We've also focused solely on their routine clinical features, so things that are regularly measured as part of their usual care. And what I will aim to show you today is research on how we think we can use these features to move beyond the current uncertainty about optimal treatment after metformin that still exists for many people with type 2 diabetes. And instead move to an approach where we can gain evidence, as shown by this 5-drug model here, actually on the relative efficacy of different drug classes in terms of glucose lowering for individual patients. I'm going to, before I get to that 5-drug model, which is brand new, I'm going to first cover a bit of background on early evidence rationale and also the way we build up these models. So starting on the early evidence for using routine features to choose the best treatment for glucose lowering. Secondly, introducing the concept of sort of outcomes-based precision medicine to use individual level clinical features to target treatment, before finally introducing this 5-drug model. So in terms of rationale, we think there's a clear rationale for why this routine feature-based approach could work, because we all know we have multiple different drug classes available to lower blood glucose in type 2 diabetes. But critically, all these different drug classes have very different mechanisms of action. We also know that people with type 2 diabetes vary hugely in their underlying pathophysiology. And so really this raises a prospect of targeting individual medications with specific mechanisms of action to specific patients based on their characteristics. And one of the earliest pieces of evidence around this came now back in 2018 in this reanalysis of the ADOPT randomized clinical trial of 2 older drugs now, SUs and TZDs. And what we showed is routine clinical features matter for response. So informed by discovery analysis in CPRD, we identified candidate subgroups, so defined by simple criteria of sex and BMI, and showed that they have very different glycemic outcomes. So as you can see on the left, slim males with a BMI less than 30 having a greater, especially early HbA1c reduction on an SU over a TZD, whereas on the right, females with a higher BMI having a greater, more sustained response with a TZD, roughly equivalent to adding a whole other drug over that time period. And what we've done since is really show other routine clinical features robustly alter glycemic response to these treatments in both routine and trial data. I think that subgroup approach was very useful for was to establish the principle of precision treatment using this approach. However, we quickly realized that actually a subgroup approach would be too simplistic to translate to clinical practice. So as this has led to us latterly developing an approach we call outcomes-based precision medicine. So using individual features of a particular patient to model their counterfactual outcomes on different drug classes and using those predictions to inform treatment selection. The earliest example of this was published in 2022 in Lancet Digital Health, and an overview is shown here. We developed a model in large unselected population-based data from CPRD, and we're actually able to just use 5 routine clinical features to predict differential response. So age, HbA1c, BMI, kidney function, and liver function. And what we were able to do was use this to develop a model that predicted differential HbA1c outcomes on SGLT2 and DPP4 conditional on those features. We would then look at the differential between those predictions and can potentially use this to identify optimal treatment. However, developing this is all well and good, but when we come to evaluate it, we immediately hit a problem, which is really the fundamental problem of causal inference, in that for an individual person, we only observe the outcome on the treatment they received and not their counterfactual outcome they would have had if they'd had another treatment. So we can't validate these models at the individual level. And so what we developed, and I'll refer you to the paper for full details of this, is a subgroup-based approach that we call the concordant-discordant framework to evaluate model accuracy. A visualization of this is shown here. So what you do is take an external validation set, ideally from an RCT where patients are randomized, split that population into two strata based on which drug is predicted to be optimal by the model. Then, taking advantage of randomization, split those groups further by the treatment they actually received, and then test whether the average difference comparing those subgroups is concordant with the predicted differences from the model. When we did this, in both CPRD validation, but critically in validation from over 2,000 patients in head-to-head RCT data for the two drugs, we showed that actually the model was able to accurately identify a large group, around 4 in 10 people, with both a predicted and an observed glycemic benefit with an SGLT2 in excess of 5 millimole per mole. At the bottom end, as shown below, we were also able to identify a smaller group with a modest glycemic benefit on DPP-4. So while this represented some significant progress, it still we still needed to develop this further to have true clinical utility, because two drugs doesn't represent clinical reality. Clinicians very broadly choose between 5 drug classes. So this has led to what I'm going to cover in the last few minutes, which is new, as yet unpublished data on developing a full 5-drug model for type 2 treatment selection after metformin. The design of this was very similar to what I previously outlined for the 2-drug model. We developed the model in large unselected UK electronic health records before validating it by UK region in the same data, as well as over calendar time, but also critically in individual level data from RCTs. The model itself is based just on 9 routine clinical features and enables predictions of 12-month response with all 5 agents, and from that evaluation of projected optimal treatment. And again, our focus with validation was on assessing the accuracy of the differential treatment effects, as previously outlined. And excitingly, what we found, and this is CPRD geographical validation, was the model had clear potential clinical utility. In particular, those receiving their treatment that was concordant with model predicted best drug actually had a greater than 5 millimole per mole, both predicted and observed glycemic benefit. And as you can see on the calibration plot here, that the model was well calibrated across this whole range of predicted HbA1c benefits. Importantly, we've also shown the model performs well in RCT data. So here we see the validation from TriMaster, which was a unique crossover trial in which participants were randomized to receiving 3 drugs in random order over a 12-month period. So this provides us data on individual level differences in response for 3 of the 5 agents in the model. Again, we can see good calibration, although a smaller average predicted and observed benefit, which likely relates to the restricted inclusion criteria of TriMaster and indeed pretty much every other RCT versus the general population with type 2. So with validation done, we were also able to take the next step and think about how implementation could look in practice. The plot here shows the proportion of individuals for whom each drug class would be identified as best treatment. What you can see is that the model would actually identify SGLT2s and GLP-1s as the predicted optimal therapy for around 7 in 10 individuals. And interestingly, you may see DPP4s are absent, and this is because they are identified as optimal therapy for less than 0.01% of people, despite their wide use in the UK up to date. So what this overall plot hides is the huge variation we see across clinical features. This was perhaps most marked by sex, where, as you can see here, we see the model identifies GLP-1 receptor agonists as the optimal treatment for around 7 in 10 females, but actually only about 10% of males for whom SGLT2s and SUs are more commonly indicated. We can also examine how optimal treatment varies across the whole range of routine clinical features. And without delving into these too much, our broad finding was that really what we're seeing is that differences largely reflect these known differences in drug mechanism of action of the different agents. Also, to highlight these two graphs at the bottom here, which stratified optimal treatment by ethnicity and deprivation. As you can see, the optimal treatment was very consistent by ethnicity and UK deprivation group, which is reassuring when we're thinking of potential model implementation, in that it indicates implementation would not increase health inequalities, in particular regarding prescribing of newer, more expensive SGLT2s and GLP-1 treatments. Finally, what we are also able to do was think about how using the model to target treatment might impact longer-term outcomes. First, we looked at glycemic failure. So that's reaching an HbA1c threshold where intensification of treatment would be strongly indicated. And as you can see here, comparing those receiving model optimal and non-optimal treatment, we saw around a 40% relative risk reduction. We were also, and this translates to around a 2.7-year difference over a 5-year period. What we're also able to show is that actually targeting treatment in this way might also associate with lower risk of cardiorenal events and microvascular complications. For cardiorenal disease, this very likely reflects that increased prescribing of SGLT2 and GLP-1 and their known cardiorenal benefits. Good, so that's all the data I'm going to show. But to summarize, we have used UK EHR to develop a 5-drug model that can help choose the best therapy for people with type 2, with potentially major benefits in terms of glucose lowering control in both the short and long term, and that associates with a lower risk of type 2 complications. Because it's routine clinical feature based, there's huge potential for it to be implemented low cost in many countries worldwide. And in terms of data science, I think a couple of key points to highlight that really this discovery validation framework using both electronic health records and RCTs has been extremely powerful as we've progressed this work. So obviously anything we can do to develop enhanced access to other cohorts as well as EHR in the UK would be fantastic. And that would be really important as we seek to further improve and optimize the model for deployment in specific populations. But really the vision is we end up with a pragmatic, low-cost approach to inform selection of type 2 treatment that really isn't there in guidelines at the moment. Please try out the app here. I can send a link on the chat as well. And just to finish by acknowledging this work is the result of a lot of work by all the people listed here, and thanks to our funders. Thank you.
That's great, John. Thank you very much. Great presentation. Lovely, exciting new data. So we will take Q&A in about 15 minutes, and let's move straight on to Carlos. Carlos, feel free to begin.
Yeah, can I say that I think the Google Doc that you shared, it's read-only, so at least I am unable to add anything, so I'm guessing everybody else, because it's still blank, just to note that. Okay, we will address that. Thank you for pointing that out. Yes, it's not a great community of practice, is it, with unable to. So anyway, far away, Carlos. Yes, let me just start a timer for myself. Right, so I'm guessing that you all can see my screen. Can see that? Yeah, PowerPoint. Perfect. Right. So thank you so much for having me here. My name is Carlos Sanchez, and I am a postdoc at the University of Edinburgh. And today I will be presenting my project. It's like an overview of the entirety of the project, and I will be focusing a little bit on the data aspect of it, or how the cohort was developed. The project is titled Impact of COVID-19 Clinical Care Pathway Changes on Gestational Diabetes Incidence and Pregnancy Outcomes in England, which is a really long way to ask the question. Sorry, I don't think I can change the slide. Yeah, to ask the question, have the changes that were put in place due to the COVID-19 pandemic, changes in GDM care or gestational diabetes care, have they had any impact in the ability to diagnose gestational diabetes or the subsequent pregnancy outcomes? First of all, let me start with a brief background into gestational diabetes mellitus, or GDM. It is a hyperglycemia that's identified during pregnancy. It is also the most common complication arising in pregnancy, and it's associated with other complications, adverse outcomes, and the development of subsequent metabolic disorders, such as type 2 diabetes for the mother and the offspring. Some of the risk factors which are also used to screen individuals for testing include age, obesity, family history of diabetes, and ethnic backgrounds. And regarding the change in testing, this happened in April of 2020, where the recommendations changed in order to prevent face-to-face or minimize face-to-face contact from the National Institute for Health and Care Excellence guidelines, which were based on the oral glucose tolerance test, or OGTT, to the recommendations published by the Royal College of Obstetricians and Gynecologists, which were based on a more opportunistic testing based on blood samples. So there was a change in how we screen and how we test for GDM. Have these changes impacted the ability to diagnose GDM and the pregnancy outcomes? That is the big question that started this project. And in order to answer it, we defined a cohort. I defined a cohort. It's an observational cohort, which is based or constructed from routinely collected data. And the goal was to include all pregnant women in England aged 16 to 50 years old, delivering from 2018 to 2023. We also defined two periods of time: the original testing period of the NICE period, which starts in January 2018 to March 2020, and the RCOG, or the intervention period, starting in April 2020 to December 2022. In regards to the sources of data that I used, these are available in the NHS England secure data environment, and the main source of the data was the Hospital Episode Statistics, or HES, which was used to define a pregnancy and to establish a delivery date. Apart from that, I also used the Maternity Services dataset and the GDPR in order to provide additional information and variables for the analysis. So just a very brief summary of the pipeline that I used to develop the cohort. As I mentioned, it is based on the HES data because it has the minimum that we need for the definition of the cohort. It has a unique maternal ID, it has maternal age, it has a delivery or an episode date, and we can get GDM diagnosis based on ICD-10 codes. And that's how we defined it. HES is actually divided into multiple subtables, so I used the main HES table and the maternity tail of it in order to merge them together, and at the end I ended up with a merged HES cohort that had 2.9 million episodes for 2.4 million unique women. I should mention that episodes refer to observations or unique recordings of events happening at the hospital, but one episode does not really relate one-to-one to a delivery. And this is where I had to develop a system to collapse episodes based on actual deliveries. You would see that there's multiple episodes for the same individual, and they often happens in very short time frames. So for example, 4 different episodes for one individual in the same 3 days. So we need to define which is the real delivery date. That's the first thing. And the second, are any following episodes the same actual pregnancy or the same delivery event, or is it a subsequent one? And we need to do this in a mechanistic way. We cannot do it by hand, obviously. So something that I noticed, is that if you plot the time difference between one episode and the subsequent one for every single person, most episodes occur within the same day to 1 week after. And then the frequency of episodes basically vanishes, and it ramps up again after 9 months, as you can see in this plot, where the same date is not plotted because it was huge. So this is what I've used for a clustering system, where if episodes for the same person, there's episodes happening in the same week. Those are collapsed into one, and that relates to a single delivery event. Then if there's episodes that happen after 6 months, 6 months afterwards, that relates, or that actually corresponds to a subsequent delivery. That's a different pregnancy. And anything in between is removed and flagged as non-reliable, unreliable. So that system was actually pretty useful, because while removing 30,000 episodes for 2,000 unique women, which is almost nothing, I made sure that what we are counting are individual events of delivery and not repeated deliveries for the same person, which are actually not true, and also allowing us to identify when a delivery happened and when a subsequent one, and different baby, a different pregnancy also happened. So after doing all of this cleaning and the clustering system, we ended up with a cohort. You can see here the number of deliveries over time, and those actually correspond to over 90% in total to those estimated by the ONS, which is really, really good, I think. Of course, after that, I also got extra information from HES, from MSDS and GDPR in order to provide more additional variables once the cohort was already established. Particularly, all diabetes diagnoses were identified through ICD-10 codes, which is not very exciting, but it was easily accessible. And MSDS provided BMI, body mass index, gestational age, birth weight, and delivery method, and GDPR was used to provide more ethnicity data. So that was everything regarding the methods. If you have more questions or you're interested in some specific part, please let me know at the end. But I have to go on some results, because otherwise it would be really boring. So at the end of all of this process, we have a final complete delivery cohort. So this is all the records are deliveries, not really start of the pregnancies. After cutting it to the dates that were interesting and doing some extra cleaning, we ended up with 2.7 million total deliveries from 2.3 million unique individuals, from which 9.95% have a GDM code attached. And to define GDM, we basically took any delivery that had a code that didn't have other diabetes previously. So if you had type 2 and then you had a GDM code, you wouldn't be categorized as GDM. You would be categorized as type 2, just to clarify that. So once we have all of the delivery cohort set up and clean and ready to analyze, the first thing that I did was to summarize it by year. And this is a huge table with a lot of numbers, but here on the right, I have a summary of the most important key points. First of all, that over time we see a decrease in the delivery rates. The number of deliveries per month or per year decreases constantly. We see an increase in the average maternal age. We see a slight decrease in the overage deprivation level, might not be a trend there. And we see an increase in deliveries from non-white ethnic backgrounds. But most importantly, here's the interesting part. There's a clear increase in the deliveries with diagnosis of type 1, type 2, and especially GDM. If we see the GDM row, it goes from 8.06 in 2018 to almost 12% 5 years later. And here you can see a really nice plot, or really clear plot, of GDM in purple, type 1 in yellow, and type 2 in teal. Obviously, type 1 and type 2 have been scaled down. Scaled down. But this is just to show that there's a clear upward trend for the three of them. So the number of diabetes cases, either GDM, type 1 or type 2, in pregnancy has increased over time. If we try to summarize GDM by deprivation category, we see that the GDM also increases over time for all of the levels of deprivation, either low in the lowest quartile, low in the highest quartile of GDM. Oh, sorry, I'm getting confused. The lowest deprivation is the highest quintile of IMD average, or the highest deprivation, which is the lowest quintile of IMD. Sorry, it's an opposite scale. Yeah, so we see that it increases for the three levels of deprivation, but the increase is greatest for those most deprived, those in the high deprivation level. And if we do the same by ethnic background, we see that again, GDM increases over time for all of the ethnic categories considered, but the absolute increase is greatest for women with Asian or Black ethnic backgrounds. So that's everything in regards to summary, or how can we see the data behaving over time. Now is the time to answer the big questions that I posed at the beginning of this presentation. So do GDM trends change by the screening method used to test GDM? So the intervention or the change happened in April 2020, but since this is a delivery cohort, that means that I estimated the deliveries from women having been tested in April 2020 to be delivering from the 18th of October 2020. So this is like a change in the threshold, like moving alongside time, but just to account for the fact that this is a delivery cohort and not a pregnancy or a booking cohort. So yeah, this is just to clarify, the original testing or NICE, it's plotted in green, sorry, and the RCOG or the intervention is plotted in purple. And I performed an interrupted time series using the daily counts or the percentage and adjusted by calendar month. And you can see here below the results from those linear regression analysis. The thing important here to take away is that the number of daily GDM deliveries and the percentage of GDM doesn't seem to, like, the effect of the intervention on the slope, on the trend, is not significant. This in either of those, even though we see a significant but small increase in the immediate change, as in there's the number increases or the percentage increases, the trend is not significantly different, which we can say that there's not a significant change in the trend, so we don't see any difference in the ability to diagnose GDM when the guidelines changed. That's the big question that we posed at the beginning. And after that, we were also interested in the outcomes for these pregnancies. So I had to reduce the cohort into a singleton subcohort. This is only taking pregnancies or deliveries for just one baby to make it more simple. But it actually accounts for 98.9% of the cohort, so the numbers are almost the same. But now we have information about their pregnancy outcomes. So we have gestational age, we have birth weight, and some interesting things to note is that there's an apparent decrease in the percentage of small for gestational age and large for gestational age babies. But also there's an increase in the number of cesarean deliveries to a decline on spontaneous births. These are the two things that we can take from these tables. So now the next thing that I will show are the comparisons by outcome. I chose small for gestational age, large for gestational age, preterm birth, and cesarean delivery. I want to say that this is very, very recent, so I'm not entirely sure how to interpret or how to give a nice conclusion to all of this. The first thing that I will talk about is that here in the right, that's a logistic regression model of the outcome, in this case, small for gestational age, adjusted by maternal age, deprivation, ethnicity, GDM, of course, and then up here, the time that's passed, the intervention, so the change from one testing method to the other, and the interaction between intervention and time. And here on the left, you can see this is just for visualization purposes. This is an interrupted time series plotting the same outcome, the monthly, for example, monthly SGA percentage, but GDM and no diabetes have been plotted separately, and GDM would be the dotted line and the non-filled circles. And again, this is just for visualization purposes. Here, the things to take from all of these four models that I will show is that GDM behaves as you would expect. It basically reduces the risk of SGA. It increases or doubles the risk of having a large for gestational age baby. It increases the risk of having a preterm birth, and it increases the risk of delivering by cesarean. If you check the deprivation and ethnicity variables, they also look as you would expect them to look. The problem here is trying to interpret the effect of the intervention, which is actually the thing that we would be interested the most. Because you would see, it's hard to talk about the four different results that if they are in different slides, but you would see that the effect of intervention and the interaction between intervention and time, they are not really consistent in their direction. And often one counteracts the other. So for example, for SGA, the intervention seems to have a protective effect, but then during the intervention time has a risk increasing effect. For LGA, you see the opposite. For preterm birth, you see, again, the opposite as in SGA. And for cesarean, you see that there's an increase. And now time is not really significant. So before giving any conclusion to this, because I don't feel confident enough, I would have to have a chat with some of my colleagues with more clinical expertise to see if this makes sense. Because something that's going on here is that we're trying to fit the data that we have to a kind of a arbitrary threshold of time. So I don't want to demerit my own work, but what I'm trying to say is that maybe this is basically a non-clinical difference that's made significant simply to the amount of data that we have, because all these models have like 2 million, well, not all of them, but they have a lot of, like, the sample size is enough so we can maybe pick up differences by simply trying to fit them. This is what I was trying to say. So as a conclusion from the regression analysis, or the big questions that we posed at the beginning, we don't see any apparent change in GDM incidence by screening method. There's no significant changes in the slope, so we may say that there's no change in the ability to diagnose based on the testing method. In regards to the risk of adverse pregnancy outcomes, we see that GDM decreases the risk of SGA, it doubles the risk of LGA, and also increases the risk of preterm and cesarean deliveries. But there's an inconsistent effect of the intervention, and often the immediate change and the slope have opposite directions. So it's quite hard to interpret, and possibly this is, as I mentioned, a clinically insignificant effect that may have been made significant due to the huge sample size that I have. So in regards to what's next, I would like to investigate the same pregnancy outcomes by GDM, that is separating, modeling GDM and no diabetes populations separately to identify differences in the odds ratio and try to find what is the difference by deprivation and ethnicity. And of course, continue working on publicating this, because even though we're still trying to figure this out and figuring the most appropriate way to present it and interpret it, the rest of the summary of how the maternity population has changed over these 5 years, I think that's valuable enough to have it. And continue receiving feedback, which I hope I would get some now. Thank you so much for having me again. And again, thank you so much to the Diabetes Catalyst group for all the continuous feedback that they have been giving me through the entirety of the project. Thank you so much.